Welcome to OncoPharm. I'm your host, John Bazar. I'm a professor of pharmacy practice at ETSU's Bill Gatton College of Pharmacy. This episode is sponsored by Kelly C. PharmD, an oncology education company for pharmacists. Apologies for last week not having an episode. It was just too busy with practice and wasn't able to do anything. And to be honest with you, needed some extra time to sift through everything presented at Asco to kind of summarize and distill, the main takeaways for me. Anyway, this is always one of the bigger episodes of the year that I have, and the big talk of Asco. Anytime there is a standing ovation, that's going to be the leader of the Asco OncoPharm podcast, and so that is RASolute 302. This is daraxonrasib. This is the third mention of this drug on this podcast. It's not even FDA approved yet. Should give people an idea of how exciting this is. The first time we talked about this was after the drug company, which is a company that does not yet have a drug that's FDA approved, to my knowledge, from looking at the website. So they're a new drug company. This looks to be their first chemical entity that maybe has been submitted to FDA. So they put out the press release saying overall survival benefit. We did a pod about that and developments in prostate cancer, and then talked about the FDA authorized the pathway for expanded access, where you can basically do N of 1 studies very quickly to get people on an experimental drug, because the FDA sees an obvious benefit for patients to get this drug, even though it's not FDA approved yet. We'll come back to that. So here's the third mention, which is the plenary session at Asco. These are the biggest papers, biggest presentations, got a standing ovation because it improved overall survival by an absolute difference of about 6 months compared to chemotherapy. So just as a refresher, since it's just so big, it's about 500 people in RASolute 302. 92% of them had RAS G12 mutations, so like KRAS G12D or G12C. 92% had those RAS G12 mutations. It was pretty common. And then the rest didn't. And they were randomized in a second-line setting of metastatic pancreatic cancer into either the RAS inhibitor, the on-RAS inhibitor, daraxonrasib, or physician's choice of chemo. Now, 40% of these folks had already received modified FOLFIRINOX or FOLFIRINOX in the first-line setting. About 35% had received gemabraxane, so a lot of these folks got gemabraxane, some got liposomal irinotecan, and 5-FU, but the chemotherapy regimens were very appropriate for the second-line setting, and the big picture here is there's improved overall survival. The 12-month OS in this study, so living 1 year with metastatic pancreatic cancer in the second-line setting, was 53%, versus 19% just in those who had RAS G12 only mutations. If you didn't have that, that was 53% versus 17%. Now that's a pretty small sample size. So from a big picture standpoint, everyone is really aware that metastatic pancreatic cancers or even early stage pancreatic cancer is a pretty bad diagnosis. Surgically, and this is a pharmacist talking, so take that. Surgically, it's in a very crowded neighborhood. So surgery is very challenging because the tumors are encasing arteries and other organs and invading other organs. So it's just a challenging neighborhood to operate in. And then there's this great review article probably 15 years ago, maybe 10 years ago, at NEJM, where they about pancreatic adenocarcinoma, where they talk about this dense extracellular matrix that can impede drug delivery to pancreatic cancer cells. And historically, people have said if you get diagnosed with metastatic pancreatic cancer, it's about a 6-month duration of survival. We know from the FOLFIRINOX versus gemcitabine study that's maybe 11 months median OS in the first-line setting. Here we have folks in the second-line setting living 12 months after randomization. So you're looking at these folks, the median survival of the fittest folks who are able to be candidates for randomized clinical trials, maybe out to maybe 2 years. So we really are, improving the standard of care here and perhaps even changing the natural history of disease on treatment. So we knew this from the press release. What we learned, because there's also the simultaneous publication in NEJM, is that the drugs seem to work in these folks who did not have these RAS 12 mutations I'm getting a frog in my throat here. So that'll be the puzzle, because this was everybody in the study, but they're really looking at these RAS12 mutations, and daraxonrasib binds to, I think it's cyclophilin, and binds to some other entity in the cell, and by binding to that, it actually makes it stickier to the RAS in the on position. That's how it ends up working. So the drug by itself doesn't really work. It needs this intracellular binding target to end up blocking RAS activation, cell cycle signaling. The question is going to be, I think, for the FDA is, are they going to approve this just in RAS G12 mutations or in the whole patient population? If you look at, and this is a lesson in how you can overanalyze subgroup analyses, if you look at the PFS in the non-RAS G12 mutant population, now this is like 41 patients. This includes RAS G13 mutations, RAS Q61 mutations, which are inhibited by daraxonrasib, and then no RAS mutations. The PFS was 1.38. It was negative, with a 95% confidence interval 0.6 to 3.17, suggesting maybe there's some harm and there's more progression in folks if they did not do that. The overall survival hazard ratio was 0.37. Looks very favorable, with a 95% CI of 0.15 to 0.93, so 15 to 93. Very wide confidence interval. This is just not enough to know. There are only 41 patients here. Don't read anything into this in the non-RAS 12 mutant population, I would say, based on this. Just too small. From a toxicity standpoint, we learned that rash, diarrhea were the most common, with rash being more common than stomatitis, some nausea, paronychia, dry skin. Sounds a lot like EGFR-mediated toxicity, and the management in the protocol that's in the appendix on the publication says, doxycycline 100 BID and topical corticosteroids for rash. And there's even a suggestion here, quote, prophylactic medication recommended, where they talk about the doxy and the topical corticosteroids. So if you were doing this in folks and using the expanded access program, I would certainly consider that EGFR toxicity mitigation approach that we know about from lazertinib and from this protocol. Part of me wonders, it's not really common for FDA to put out an expanded access program for a drug. We have drugs like daraxonrasib that are tyrosine kinase inhibitors that are approved via accelerated approval pretty commonly, and this doesn't happen. So here, it's a phase 3 study. There's overall survival benefit. There's no doubt it's going to get an FDA approval. It takes a lot of work to get an FDA approval from the drug company. You got to submit a lot of paperwork, a lot of data. It's the first time this company is doing it, and I do wonder if perhaps, I'm just speculating here, if the FDA is wise in predicting that maybe that process will take longer with the new company, and they're giving an on-ramp to this drug with the expanded access program. Just speculation. Who knows? Certainly not me. Okay. The next big study was Majestic-9. This is second-line teclistamab in multiple myeloma, and this is compared to either PVD, so pomalidomide, Velcade is the bortezomib, and Dex, or either Kyprolis, which is carfilzomib, or dexamethasone. So PVD or KD was the physician's choice control arm. An outdated, probably, control arm at this point, but one that has been, is still kind of snared in the eyes of the FDA, and certainly when this was done. So some folks kind of knocked the control arm here. It's the best that we got. It's about 600 patients. The median age here was 70, with a range of 34 to 86. I haven't seen a lot of 30-year-olds with myeloma, but if they had it, they were on this study. Now, the background here is Majestic-3, which was teclistamab and daratumumab versus a similar population showing big improvement in overall survival. Everyone's like, this is going to be tech dara for everybody. However, that patient population had not received daratumumab in the past, had not received CD38 monoclonal antibodies. This patient population of 600 patients, 100% had previous CD38-directed monoclonal antibody therapy like daratumumab or isatuximab. 85% of these folks were CD38 refractory. So these are folks that you would not be doing tech dara. Maybe you would do tech, and based on, spoiler alert, you would based on this study. So the The median, the 18-month estimated progression-free survival. So if you look at the Kaplan-Meier curve, go to 18 months. These are the people alive without death or disease progression. 69.8% versus 26.9. Hazard ratio of 0.29. The 95% confidence interval is 0.23 to 0.3. That's pretty tight. Huge benefit in PFS. We would expect a huge magnitude of benefit in OS. 18-month OS, 79.2% versus 68.6%. Not as stark of a difference. That hazard ratio is 0.6 with a 95% CI 0.43 to 0.83. You might think, oh, well, you can use teclistamab in the third line setting. That's probably going to mitigate, why we're not seeing a huge separation in OS. Yeah, that's probably true. There's some infectious concerns here. This was in Majestic 3, where they changed the protocol to mandate, monitoring of IgG levels and giving IVIG, and lowering the dose of teclistamab in Majestic 3 as well, because they were doing a fixed dose, which was too much for some folks, and went back to the weight-based dosing. Here, the infection rate in teclistamab was 82.8% versus 68.2% in the control. Grade 3 or 4 infection was 42% versus 29%. Opportunistic infections occurred in 14.4% in teclistamab versus 6.4% in chemo. Fatal infections, 5.5% versus 2.8%. The authors of the study seem to account for this higher infection risk by saying the physicians did not monitor IgG and replace IVIG as well as they should. Half of the patients with the last IgG, half of the patients who died in the teclistamab or fatal infections, half of them had their last IgG level of less than 400, which is when you would typically do IVIG. So, again, really exciting data we have for teclistamab in a second-line setting. This is going to be the big question mark. Do these folks do CAR-T targeting BCMA or teclistamab targeting BCMA? That is much easier to do in community practices. That is going to be debated, and hopefully we'll see some phase 3 studies that look at that coming pretty soon. But really, really exciting stuff for teclistamab and Majestic 9. All right, the third study I want to talk about is not the most popular study at ASCO. It wasn't one of the plenary sessions, but I found it really fascinating. This is Initsmeran autogene plus pembro versus pembrolizumab, a phase 2b 5-year update. It's a phase 2b study. What am I talking about? Well, it's pretty cool. It's basically a treatment vaccine for melanoma. So these were folks, only 157 folks. It was a stage, or phase 2b study from Australia. Australians, one of my favorite books is Bill Bryson, In a Sunburned Country. There's a reason the Australians do a lot of melanoma research. So these were stage 3B or 4. So if some of these folks had metastatic disease, resected melanoma, and they're randomized to Initsmeran autogene, which sounds like a cellular therapy. It's not really cellular therapy. So they're taking tumor sample and then blood sample from these patients. About 100 got Initsmeran autogene plus pembro. The other just got pembro. After surgical resection, and then they're getting basically a year of pembro or up to 9 doses of this individualized mRNA, basically treatment vaccine. And so they're taking tumor sample and blood sample, and they're trying to figure out a constellation of neoantigens. It's not just one neoantigen that they cook up in this IM dose. It's basically like a vaccine, okay? And now we have this, up to 5 years, and we're reporting here, what I have is the recurrence free survival at 1, 2, 3, and 4 years. And I'll do pembro first. So you can think of this as natural history disease. You got 3B, an advanced or even stage 4 NED melanoma. How long do you go without your disease coming back or dying? So for pembro, this is 1 year, 2 year, 3 year, 4 year. 62%, 60%, 56%, 49%. Still 4 years, half the people alive, some of them with metastatic melanoma. That's really encouraging, right? And we know that with immune checkpoint inhibitors. The numbers would be even higher if they got a PD-L1 inhibitor like nivolumab or pembro plus ipilimumab most likely. So here's the data now for the experimental drug, Initsmeran autogene. 1 year, 2 year, 3 year. 80%, 78%, 74%, 72%. Now the delta at 4 years is 23.3%, so from 49% up to 72%, and they're not getting any treatment after that first year, okay? So really, really encouraging, promising effect size. This is a phase 2 study. It's less than 100 patients. Oncology is littered with promising phase 2 studies that are not confirmed in phase 3. There's obviously a technical component to this that may have some scalability issues, but really, really exciting. If I had resected melanoma, this is the type of study that I would want to be on. A lot of listeners to this pod, they're actively trying to learn oncology, whether they're new to the specialty or just trying to deepen your understanding of a particular disease state. To help, Kelly Karlstrom, founder of Kelly C. PharmD and the ELO Collaborative, created the Learning Oncology Companion. It's a free template that provides a structured framework for learning any cancer type. Kind of starts with, what is the cancer, the staging, histology? Are there biomarkers we need to know about? Is it chemo? Is it surgery? Is it both? It's basically a template where the learners fill this in, and it's a guide to how to think through every malignancy. And it really helps you organize key concepts like these risk factors, symptoms, and you can download this Learning Oncology Companion using the link in the show notes for free. Okay, back to some of the big plenary sessions. So Libretto 043, this is adjuvant selpercatinib in stage 1B to 3 RET-fusion positive non-small cell lung cancer, also a simultaneous publication in the New England Journal of Medicine. Some years ago, many years ago, I had a really bad take. I saw a commercial for a cell phone with a camera, and I said, no one is going to do this. That was a bad take. Several years ago, I have a podcast questioning the role of adjuvant TKIs, saying, are we really curing more people? I don't think this should be a thing. This has clearly become a thing now, whether it's adjuvant osimertinib in EGFR-mutated non-small cell lung cancer, adjuvant BRAF MEK inhibitors in melanoma, or in other cancers as well. So this is adjuvant selpercatinib. It's a small study, 150 patients, and they actually cut out the 1B, and they're just looking at stage 2 and 3A in their primary analysis, which is only 109 patients. So these patients are randomized to 3 years of selpercatinib or placebo. They got chemo first, so like 90% of people in the stage 2 to 3A already got chemo. They got platinum-based chemo. And this event-free survival, there's big separation here in our event-free survival curves. It's kind of hard to do percentages because the numbers are so small, so I'm going to do actual number of either recurrence events, progression events, or death events. So in those who got selpercatinib, 4 out of 54 had an event versus 19 out of 55 in the placebo arm. That's a hazard ratio of 0.17, and that's a 95% confidence interval from 0.08 to 0.87. I can't read my writing. Pretty wide confidence interval, though, because you do have only 50 patients on each arm. If you look at the whole patient population, the number of events is 4 out of 75 versus 20 out of 70 when you include the 1B. And if you look at the subgroup analysis, and I've already talked about the hazards of looking at hazard ratios and subgroup analyses, I think there's something here, though. If you look at those who are stage 2, that hazard ratio is 0.68, 95% CI 0.11 to 4.08, right? Like incredibly wide. The hazard ratio for the 3A patients is 0.1, 0.02 to 0.43. So the benefit we see here is overwhelmingly driven by those with stage 3A disease. Whether the stage 2 folks derive benefit, I think that's an unanswered question. You probably give them the benefit of the doubt. I'll come back to the point that if we're doing TKIs, are we curing these folks, or are we pre-treating, micrometastatic disease? Okay, and we're not going to maybe cure them because we're really blocking the growth of these cancers. That's a theory. Okay, now where this is going to go, I think there was a study that I heard about on NPR. It's written in the New York Times for about a week ago. There's a study published in Cell where a group of researchers are looking at, like, proteomics, I think. They're looking at proteins in the blood of people who went on to develop EGFR-mutated non-small cell lung cancer, and they've kind of derived a blood test that they think can predict the development of EGFR-mutated non-small cell lung cancer years in advance. Well, those would be the folks where you might look at such a blood test as a randomization for a study like this versus maybe 1A and stage 2. But regardless of what I think, adjuvant selpercatinib is going to be in the guidelines. We'll be doing it in our RET-fusion positive folks for sure. And most of these folks did get chemo. 90% in the stage 2 and stage 3 did get chemo here. So that would I would do what they did. All right, next study to talk about is the PROTEUS study. Very, very interesting that they named the study after a genus of bugs that can cause UTIs. It'd be like if you had an E. coli study or a Pseudomonas study. But PROTEUS, this is perioperative apalutamide in high-risk localized prostate cancer. Whereas Libretto 043 was 157 patients. This is 2,100, more than 2,000 patients. And they're high-risk localized prostate cancer. They're getting ADT for 6 months, then prostatectomy, then ADT for 6 months. And they're getting either apalutamide or placebo for the same 6 months pre and 6 months post prostatectomy. Two primary endpoints here: pathologic complete response rate or minimum residual disease as a composite, and then metastasis-free survival. PCR or MRD was 9% versus 1%. Okay, huge difference, but going from 1 to 9% is not that impressive necessarily. Metastasis-free survival at 60 months was 78.3% in apalutamide versus 73.5%. That's a hazard ratio of 0.8, a 95% confidence interval of 0.67 to 0.96, and that's with 2,000 people, 2,000 plus, and you get a hazard ratio of 0.8. If you look at the Kaplan-Meier curve of the patients at risk at the 60-month mark, that's down to 300 or so. From 2,000, I'm really curious to see what the full long-term metastasis-free survival looks like, since that was our primary endpoint. It's very possible that this statistically significant result may not be statistically significant after long-term follow-up. The Kaplan-Meier curves do not separate at all till after 3 years, which, okay, it's a perioperative approach that could be reasonable. I really do wonder if this is clinically significant, though. It's a pretty small benefit that we're seeing. This could be an example of where you overpower a study so that a clinically insignificant endpoint ends up being statistically significant. More to sort through with this. A lot of folks were not excited about this. If you read people talking about it, usually everyone in oncology is excited about everything. A lot of folks were, I think, surprisingly to me, kind of cool on this study. So it'll be interesting to see how this approach, if it is adopted and if it takes off. The last kind of big study I talk about is SARC-04. I think it's SARC-041. It's a sarcoma study. It's a phase 3 study of abemaciclib versus placebo in advanced dedifferentiated liposarcoma. 108 patients got randomized to abemaciclib 200 milligrams once a day, or 54 to placebo. And the median progression free survival was 9.7 months versus 1.5. Obvious benefit, hazard ratio 0.39, 95% CI 0.25 to 0.59. Response rate 9.3% versus 0%. So this is unpublished, and if you search on X or Twitter, you can see some pictures of the slides from Asco. Patients were stratified by 0 lines of treatment to 1. So some of these folks got placebo and had never had treatment, which is a little odd to me, but clearly a drug that has benefit. Always need drugs for sarcoma. And then the last study to talk about here is the 7-year follow-up of CROWN. So CROWN is adjuvant lorlatinib in ALK positive advanced non-small cell lung cancer. And what I want to talk about here is the 7-year PFS rate in lorlatinib is 55%. So you have folks with this type of lung cancer, it's metastatic, 7 years later, more than half are still alive without disease progression. That number was 60% at 5 year. Still pretty good 2 years later. So we're seeing some evidence here that we can perhaps, in some of these people, turn this into a chronic disease. I mean, 7 years, yeah, it's a chronic disease, right? For sure, it's a chronic disease then. So that's just further reinforces the value and how far we've come in understanding the biology of these cancers. When I started I'm in my early 40s. When I started in oncology, we treated all non-small cell lung cancers the same way. and now we know histology makes a difference, and there's a huge difference here for our EGFR, ALK, and our RET mutated, like we talked about with the Libretto 4-3 study. So that is not certainly everything that happened at ASCO, but that's what I'm talking about that happened at ASCO. And I've been talking long enough. Thank you so much for following the podcast and liking the podcast, talking about it, spreading the word. You can follow me on X at PharmDeetnib and other social media platforms at OncoPharmPod. And until I talk to you again, remember, doses matter.